This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from Child's Nervous System, published in 2026, titled Surgical Resection in Medulloblastoma, a Crossroads in the Molecular Era. The lead author is Joseph H. McCabe, and it comes from a collaborative group involving the NIH, St. Jude, and other major centers.
This is a timely discussion, Alora. Medulloblastoma remains the most common malignant primary brain tumor in children. Even in 2026, we're still grappling with the balance between aggressive surgery and post-operative quality of life. The paper notes that while about a third of these children eventually succumb to the disease, survivors often face significant morbidity, not just from the disease itself, but from our treatments.
Exactly. And the paper sets the stage by looking back at how we reached our current standards. For decades, the gold standard for what constitutes an adequate resection has been based on the CCG 921 study.
Right, CCG 921. That study was conducted back in the 1980s and 90s. It's where that famous, or perhaps infamous, 1.5 square centimeter threshold for residual tumor came from.
It's interesting how the authors describe that threshold. It wasn't based on an a priori biological hypothesis. Instead, it was reached through an iterative statistical process. They essentially kept moving the line until they found a point that created a statistically significant separation in the survival curves.
And back then, they were primarily using CT imaging. They found that if the residual tumor burden was less than or equal to 1.5 centimeters squared, which they defined as near total resection, or NTR, the progression-free survival was significantly better compared to a subtotal resection, or STR, where the residual was greater than 1.5 centimeters squared.
And that became the benchmark. Subsequent trials like PNET-4 and the COG trial ACNS-033 corroborated that having more than 1.5 centimeters squared of residual disease was associated with a worse outcome. But the authors of this new paper suggest we are at a crossroads because that rule is being questioned.
It's being questioned because the world of neuro-oncology has changed. We aren't just looking at histology anymore. The paper describes the 2012 publication by Taylor and colleagues as a seismic shift for the medulloblastoma community.
Right. That's when we moved into transcriptional profiling and genetic mutation patterns. We went from just medulloblastoma to 4 distinct subgroups: WNT, SHH, Group 3, and Group 4. And as the paper mentions, the 2021 WHO classification refined this even further, separating SHH into TP53 wild-type and TP53 mutant, and incorporating wide-scale methylation profiling.
This is the core of the controversy the authors are highlighting. If the biology of a WNT tumor is fundamentally different from a Group 3 tumor, does a 1.5 square centimeter residual carry the same weight for both?
That's the million-dollar question. The authors point out that some European researchers are even suggesting that STR alone, subtotal resection, should perhaps not be considered a high-risk feature when we're planning adjuvant therapy anymore. They are reconsidering the impact of the extent of resection, or EOR, specifically within the context of these molecular subgroups.
It's a shift in philosophy. We've always said maximal safe resection, but safe is the operative word there. The authors are very clear. The goal is to cure the disease while minimizing treatment-related toxicity, and that includes surgical injury.
They mention how much our tools have improved since the CCG 921 era. We've gone from primitive CT scans to advanced MRI technology and subspecialized pediatric neuroradiology. We have intraoperative ultrasound and intraoperative MRI, which allow us to assess the EOR in real time.
And yet, despite all this tech, we still see cases where the pursuit of that last bit of tumor, trying to get under that 1.5 centimeter threshold, leads to neurological deficits. The paper asks if it's possible to maximize resection to improve survival and adjuvant efficacy while minimizing that morbidity.
Let's dive deeper into the subgroup implications mentioned. If we look at the WNT-activated subgroup, which generally has an excellent prognosis, does an aggressive resection that risks a cranial nerve palsy make sense if the adjuvant therapy is highly effective?
That is exactly where the crossroads are. For a WNT tumor, the survival benefit of going from an STR to a GTR might be negligible compared to the functional cost. Conversely, in a high-risk Group 3 or a TP53 mutant SHH tumor, perhaps every millimeter of cytoreduction counts more. The paper suggests that we are moving away from a one-size-fits-all surgical goal.
It also highlights that the 1.5 centimeter squared rule was somewhat arbitrary from a surgical standpoint. As surgeons, we don't think in square centimeters intraoperatively. We think in terms of brainstem infiltration, adherence to the floor of the fourth ventricle, and the preservation of the cerebellar peduncles.
Precisely. The authors note that the original CCG 921 study showed that intraoperative observations by the neurosurgeon were often inaccurate compared to postoperative imaging. That's why that quantifiable imaging measurement became the gold standard for clinical decision-making. But now, with molecular tailoring, the standard is becoming more nuanced.
I found it interesting that the paper mentions how adjuvant treatment approaches are being tailored to these subgroups. If the chemo and radiation are being adjusted based on the molecular profile, the surgical goal should probably be part of that tailored plan.
It's about the adjuvant treatment efficacy. The logic used to be that a smaller tumor burden is more amenable to effective control by radiation and chemotherapy. While that's generally true in oncology, the authors are nudging us to ask, is the 1.5 square centimeter threshold the right biological marker for that efficacy in the molecular era?
And they don't seem to think it necessarily is. They point out that the validity of this threshold is being questioned, especially when we look at the survival curves in the context of molecular signatures.
So, for the residents and students listening, what's the takeaway? The paper isn't saying stop trying to resect the tumor. It's saying we need to balance the known benefits on treatment efficacy and survival with the minimization of neurological morbidity.
It's about being smarter surgeons, not just more aggressive ones. We have to utilize the intraoperative technology the authors mention, ultrasound and IMRI, to know exactly where we stand during the case.
And we have to stay integrated with the neuro-oncology team. If we know the molecular subgroup from a fast-tracked biopsy or specific imaging characteristics, it might change how hard I push at the floor of the fourth ventricle.
The authors conclude that we are in a transition period. We have the historical data of the 1.5 centimeter squared rule, but we are moving toward a future where EOR is just one variable in a complex molecular equation.
It's a fascinating time to be in the field. This paper really highlights that we can't rely on 30-year-old statistical iterations forever. We have to evolve as the science of medulloblastoma evolves.
Definitely. It's a call for a more personalized surgical approach.
Well, that's a great place to wrap up our discussion on this paper. For our listeners, the full article, Surgical Resection in Medulloblastoma, A Crossroads in the Molecular Era, is available in Child's Nervous System.
Thanks for joining us on the Neurosurgery Hub podcast. We'll see you next time.
Stay sharp.